Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. The cardiology seminars are brought to you by Triple N Media. Our YouTube channel has more than 200 cardiology lectures, and we welcome you to watch them. And we also kindly request you to subscribe to our YouTube channel so we can notify you of our new additions to the cardiology lectures. The information provided here is for education and entertainment purpose only and is not a medical advice. If you want me to research on a particular topic and produce a video, please let me know and I'll be happy to do that. If you would like to receive a copy of my cardiology rotations manual, which has 175 pages of very pertinent information about cardiac patient management in the hospital or in the office, please stay tuned. I will tell you how to get a free copy of this booklet. The feature presentation for this seminar is Tachycardia, Differential Diagnosis. You are called in to see a patient in the emergency room with a heart rate of 170 to 180, and you arrive at the emergency department. You look at their monitor, you look at the electrocardiogram. What do you do next? We need to establish what kind of rhythm are we dealing with? How bad is the rhythm? And what is the patient's clinical condition? And based on these, we may have to institute prompt treatment. So let us walk through this differential diagnosis so the next time you see a patient with a tachycardia, you won't be sweating like the patient. Whenever we see a patient with a tachycardia, of course, we need to assess these patients using A, B, C, D, E approach as we would do in any patient with a cardiac emergency. Airway, breathing, circulation, etc. If the patient needs to get oxygen, IV fluids, and we get an EKG, blood pressure, and oxygen saturation, and a 12-lead electrocardiogram, of course. Then we identify any reversible causes such as electrolyte abnormalities or elevated cardiac troponins, which may signify something underlying going on. Next question is this patient in shock? Does the patient have a history of syncope? Does the patient have myocardial ischemia, which I just talked about? Is the patient in heart failure? If a patient has a rapid heart and if the clinical condition is unstable, like the patient is having low blood pressure, low oxygen saturation, and is having significant shortness of breath, the treatment of choice is Synchronize cardiac defibrillation, Synchronize DC shock before you arrive at a diagnosis. That followed by amiodarone 300 milligrams IV bolus over 10 to 15 minutes. And then this is followed by 900 milligrams of amiodarone over 24 hours. That is assuming the patient is unstable and you are dealing with a very rapid heart rate with unstable vital signs. If the patient is stable, the next step is to determine is the QRS complex broad or wide versus a narrow QRS complex. If the QRS complex is less than 120 milliseconds, then we are dealing with a narrow QRS tachycardia. First, let us address the narrow QRS tachycardia, then we're going to come back to the broad or wide QRS tachycardia, because it can include both supraventricular and ventricular tachycardias. Okay, when we are dealing with a narrow QRS tachycardia, the next question is the rhythm regular? Like the RR intervals are constant, like in a patient with paroxysmal atrial tachycardia or atrial tachycardia, or in fact atrial flutter with 2-to-1 conduction. On the other hand, is the rhythm irregular? If the rhythm is irregular, the patient is having rapid heartbeat, we need to consider the possibility of atrial fibrillation with rapid ventricular response. And these patients can be treated with beta blockers or diltiazem, or we can use digoxin and amiodarone depending upon the clinical condition. On the other hand, if the rhythm is regular, like you're having a constant RR interval, like in a patient with atrial flutter with 2-to-1 conduction with a ventricular rate around like 160, 170, or paroxysmal atrial tachycardia with a heart rate ranging from 180 to 200, then you use adenosine 6 milligrams IV rapidly. If that is unsuccessful, you use a second dose using 12 milligrams of adenosine. If the second dose doesn't work, we repeat the third dose, which is again 12 milligrams of adenosine. In the meantime, we monitor their oxygen saturation, EKG rhythm, blood pressure, and color. If a sinus rhythm is restored, then we are probably dealing with a re-entry tachycardia. Then we get an electrocardiogram and continue with the cardiac evaluation and management of patients with tachycardia in terms of determining what is the underlying cause for this tachycardia. Is this an accessory pathway, or is this AV nodal re-entry, or is there a trigger mechanism somewhere? All right, if the rhythm is not established, then we should consider the possibility of atrial flutter. Because the atrial flutter, the rhythm may slow down for a short while and it may go back again to 2-to-1 conduction with a ventricular rate ranging from 150, 160, 170 beats per minute. And if that's the case, we need to control the ventricular response with beta blockers and get a cardiology consult, because atrial flutter has a higher tendency of patients developing clots if they had the atrial flutter for a while, and hence they need much more workup in terms of anticoagulation to make sure they don't have clot before we try to cardiovert these patients. Now let's get back to wide QRS tachycardia. If we are dealing with a wide QRS tachycardia and if the RR intervals are irregular, when you see an RR intervals which are irregular, a couple of things we need to consider. Number one, atrial fibrillation with rapid ventricular response with aberrant conduction. The other thing is a patient with a WPW with atrial fibrillation with wide QRS tachycardia with varying morphology from beat to beat. Okay, if we are dealing with an irregular rhythm with a wide QRS tachycardia, we need to seek expert help, because it could be just atrial fibrillation with an underlying bundle branch block. If so, you need to look at their previous electrocardiogram and see if the bundle branch block was there. If there was no bundle branch block and you see a wide QRS tachycardia with varying RR interval, it could be aberration, or it could be even a patient with a WPW. When a patient with a WPW develops atrial fibrillation with rapid ventricular response, the usual drugs like beta blockers and calcium channel blockers may block the AV node and increase the conduction through the accessory pathway, which can result in worsening of the rhythm. So the treatment for a patient with a WPW with the atrial fibrillation with rapid ventricular response is procainamide. We can also consider amiodarone, but first choice of drug would be to use procainamide intravenously. If we are dealing with a irregular wide QRS complex, and if it looks like torsade, then we can treat this patient with magnesium 2 grams IV as an infusion. On the other hand, if we have a regular wide QRS tachycardia, like the Gordon variety, 150, 160, 180 wide QRS tachycardia, symmetrical QRS complexes, and the blood pressure is sort of borderline, then you know you're dealing with most likely ventricular tachycardia. If we are dealing with ventricular tachycardia, then the option would be to use amiodarone 300 milligrams IV bolus followed by 900 milligrams of over 24 hours. You start off with 1 milligram per minute, then after 6 hours you drop it to 0.5 milligrams for the next 18 hours. So the maximum dose should be less than 2.2 grams per 24 hours. If we have a regular tachycardia with a wide QRS complex, we could still be dealing with a supraventricular tachycardia like sinus tachycardia or paroxysmal atrial tachycardia with an underlying bundle branch block. If we know the condition and if we have a previous EKG which might help, these patients may respond to adenosine, which will slow their heart rate, and in cases of paroxysmal atrial tachycardia, it may even terminate the tachyarrhythmia. So that's one way to approach that. So ladies and gentlemen, this is a quick overview of how you deal with a patient with a rapid heartbeat, anything that is more than 100 up to like 220 or 230. Because when you go beyond that, it's an emergency. Obviously, they all need to go for cardiogenic shock, especially if they are in a state of shock. So ladies and gentlemen, if you would like to get a copy of my cardiology rotations manual, please send me an email at drniknikam@gmail.com, and I will be happy to send you a free copy. Please do subscribe to our YouTube channel, where we have more than 200 cardiology lectures, and we are adding several lectures each day and each week. And if you want us to prepare a particular topic, I'll be more than happy to do that. This cardiology seminars is brought to you by NNN Media. I am Dr. Nik Nikam, and please do subscribe to our YouTube channel. I will see you in the next video.